Our fourth lecture for today is about fibromyalgia, to be presented by Dr. Kholoud Saleh, consultant rheumatologist and head of Rheumatology Unit, Pharmacologic Hospital.
Thank you. Assalamu alaikum. Thanks for coming today. And I'd like to take this opportunity to thank Rheumatology Unit from Mubarak Hospital for organizing such a wonderful activity, which I think it's going to be very helpful and a good start with the GPs. So I'm going to present fibromyalgia today. Here are my objectives. We'll know the definition of fibromyalgia and the possible causes. We'll know the new diagnostic criteria of fibromyalgia, and then we'll know how to manage these patients. So what is fibromyalgia? Fibromyalgia is a chronic, non-inflammatory, non-autoimmune central afferent processing disorder that leads to diffuse pain. So these patients present with multifocal pain, excessive and severe fatigue, excessive stiffness, sleeping disturbances, cognitive problems, and psychological distress. The estimated prevalence in the States was found to be 3 to 4%, so it is commoner than rheumatoid arthritis. It is a female disease, so it affects females predominantly. It has been found that 70 to 90% of these patients are female. The peak age of onset is between 30 to 55 years old. So if you have a patient with such symptoms and you came up with this diagnosis, you have to revise your diagnosis before making it in a 55 or above than this age. You have to dig in very well and to look for underlying serious problems if you have such a patient presented for the first time with excessive pain and fatigue. So as it is a central afferent processing problem, what about their brain MRI? Their brain MRIs are totally normal in these patients. But the functional brain studies, such as SPECT and functional MRIs of these patients, in many papers shown to show decreased regional brain blood flow. So here is the old, or the fibromyalgia ACR 1990 classification criteria. By the way, I'm still applying this criteria for my female patients. So there are 3 components of this criteria. So these patients present with chronic widespread pain for at least 3 months. So what does that mean, chronic widespread? So their pain should be above and below the waistline. It should be on both sides of the body, and it should be there for 3 months. The pain is also induced by palpating at least 11 out of 18 tender points, and I'm going to show you these tender points. And there should be no other explanation of these symptoms. So here are the 18 fibromyalgia tender points. We have 6 at the front, and then we have 12 on the back when you examine these patients. So you have to press until your nail bed blanches. Don't press so hard, because you are going to induce their symptoms, and these points are really tender in these patients. Because these fibromyalgia tender points are negative or normal in male patients, so in 2010, ACR came up with the preliminary diagnostic criteria for fibromyalgia. There are 2 main components: the widespread pain index and the symptom severity score. And again, these symptoms shouldn't be explained by other symptoms and by other diseases or problems, and their symptoms should be there for at least 3 months, so it's a chronic problem. So what is the widespread pain? So you have to ask the patient for pain in specific areas. So you have to give 2 points for each of these joints: temporomandibular, shoulders, upper arm, lower arm, hips, upper legs, and lower leg. And 1 point for each: neck, chest, abdomen, upper back, and lower back. The maximum score here is 19. What about the symptom severity scale score? There are 4 components or items here. We have the fatigue, wakening from sleep unrefreshed, cognitive disturbances, and somatic symptoms. So any tingling sensation, burning sensation, this is somatic symptoms. And the score scale here ranges between 0 to 3. Maximum score here is 12. So what is 0 to 3? If there's symptoms, I'm still talking about the symptom severity scale. So if there is no symptoms or no problems with the 4 components, they score 0. If they have mild or slight problem with these components, then they score 1 for each of these components. If they have moderate symptoms, then you give them 2 points. And if they have severe problems, then they score 3. Maximum score, because we have 4 components, by 3, so maximum is 12. So the patient satisfies the 2010 fibromyalgia clinical diagnostic criteria if the WPI equals to 7 or more, and the symptom severity score equals to 5 or more, or if the WPI between 3 to 6 and the symptom severity score more than or equals 9. Okay, so what are the possible causes, or how does it develop? Those patients, this is a theory, those patients are genetically predisposed to have fibromyalgia. They are just waiting for the triggering event. This triggering event could be either accident, physical abuse, serious illness, or abnormal stress. And then when this trigger is there, then the fibromyalgia starts. And then they will develop the negative feedback loops. What about the other triggers beside the trauma and the acute illness? They can have also underlying sleep apnea. And fibromyalgia could be also secondary to connective tissue disease, especially in lupus patients and RA. And in one paper, they have estimated that up to 30%, so 1/3 of patients with lupus or RA can develop fibromyalgia. And other triggers such as catastrophic events, post-traumatics such as post-war, and some of these patients may have chronic psychological disorder as a trigger factor. Okay, so this is an example. If the patient has injury or disease, they will have limited activity because of this issue, and then eventually they will develop muscle tension and distress. After that, they will start to have stress and anxiety because they are unable to live their activities of normal living, and then they will have poor sleep and pain. And this will be like a continuous cycle or a vicious cycle that does not end unless we break it with our strategies or therapy. What about other symptoms? So beside the diffuse pain, it has been found that up to 80% of these patients can have fatigue, non-restorative sleep, arthralgias, myalgias, stress, and up to 1/3 of these patients can have cognitive dysfunction, like problems in concentration or short-term memory, and they can have also muscle spasm, paresthesias, depression, and anxiety. Up to 60% of these patients can have tension or migraine headache, and up to 40% can have symptoms of irritable bowel syndromes. And some of these patients may come with restless leg syndrome, and some of them can have also irritable bladder due to underlying cystitis, which is quite common in fibromyalgia patients. Some of these patients also can have primary dysmenorrhea, temporomandibular joint disorders, and hypersensitivity to chemicals such as odors and bright light. So in approaching these patients, if you have a patient who comes to you complaining of excessive fatigue, diffuse pain, you have to sit with the patient, take really good history. So in your history, you have to elicit any symptoms or signs from your examination of underlying disease that can explain their symptoms. So for example, if you have a young female who comes to you with excessive fatigue and generalized pain, you have to take appropriate history of lupus. So you have to ask about arthritis, you have to ask about photosensitivity, oral ulcers, excessive hair loss, you have to even to ask about obstetric history. And of course, you have to ask about Raynaud's and the rest of the connective tissue symptoms. Constitutional symptoms, history is very important because patients with fibromyalgia do not have fever or significant weight loss. So if they do, then you have to look for an underlying serious problems. On physical examination, you have to examine patients very well, looking for signs of connective tissue disease or underlying malignancy. And in laboratory tests, you have to ask for routine initially, so CBC, ESR. High ESR should be abnormal finding in patients with fibromyalgia. So if they come with high ESR or CRP, you have to look for underlying connective tissue disease, infection, or malignancy. I'm sure you know all these differential. And of course, baseline metabolic panel. Thyroid, hypothyroidism is one of the differential of fibromyalgia. You shouldn't make the diagnosis of fibromyalgia if the patient has a hypothyroidism by test or if they have low vitamin D, which is quite common in Kuwait. And you have to correct those before making the diagnosis of fibromyalgia. And please do not order rheumatoid factor or ANA as a routine unless if there is objective joint swelling or rash suggestive of connective tissue disease. Other tests that you may consider only if there is objective finding are EMG, nerve conduction, and MRI. What about the treatment of these patients? So we have two components here. We have the non-pharmacologic strategies and we have the pharmacologic therapies. There are 7 non-pharmacologic strategies in these patients. So first, patient education, and I will explain this shortly. We have to correct their sleeping problem. Aerobic exercise has very important role in managing these patients. Physiotherapy also has a very important role in these patients as well. Then we have our different treatment with the different drugs, and we have to treat the underlying disorder if there is. And of course, cognitive behavioral therapy, we have to consider it in some of these patients. So patient educations, whenever I face this case, I have to spend some time. So fibromyalgia patients usually are type A personality. They don't let you talk. They just want to talk, and they do not believe that there is nothing wrong with their blood work or physical examination. Maybe you are doctor number 10 who comes to see this patient. So you have to spend some time. They have to believe that this is a real and objective disease. Unfortunately, some physicians do not believe that this is a disease. Some physicians will refer them to psychiatry hospital because they believe that this is not a disease. It is a real disease. They should know that. But again, they should know that there is no serious underlying problem. They have to face this fact. Because they are type A personality, you have to sit with them and ask them, please, you have to slow down, you have to have personal time for you, and you have to relax. You have to do some priorities for the things you are doing every day. So don't overdoing things. You have to take some time for yourself. Sometimes I need to talk to the husband or to the partner in order to help them out because they really need help. And of course, those patients should have substantial control over many components that I already mentioned. And it will be really nice if you give them educational handouts when they leave your clinic. What about the exercise or physiotherapy? The goal of exercise here is to improve muscle conditioning that will lead to less muscle microtrauma and to improve non-restorative sleep, which will increase eventually the endogenous endorphin and the CNS. And the aerobic exercise should not be high impact exercise. So walking and swimming are more than enough for these patients. What about the pharmacologic therapy in these patients? We have 3 FDA approved medications for treatment of fibromyalgia syndrome. We have 2 of them available in Kuwait. So we have Cymbalta, which is used in patients with fibromyalgia and depression. And we have the pregabalin, which is Lyrica, that is also used in fibromyalgia patients with profound sleep disturbance. Savila, I don't have it in Farwani. I'm not sure if it is available in different parts of in Kuwait. It is used in fibromyalgia patients with cognitive dysfunction. Other medications that shown to be very effective in patients with fibromyalgia, and it is a really good alternative or choice in non-Kuwaiti patients, are tricyclic antidepressant like amitriptyline. We have Effexor, which is serotonin norepinephrine reuptake inhibitor, or dual inhibitor, reuptake inhibitor. We have Neurontin and some muscle relaxant like baclofen or cyclobenzaprine to treat stiffness symptoms in these patients. We have also SSRI, which is used mainly in depressed patients. Some analgesics like NSAIDs can be used, or tramadol to relieve their pain. And we have modafinil that we don't have it actually in Farwani Hospital to treat patients with central nervous system problems. It's a stimulant, so excessive fatigue patients. And please do not use opioids or corticosteroids, as they are not effective in these patients and they should be avoided in fibromyalgia patients. So here is a summary of what I said. This is a fibromyalgia treatment guidelines of professional organization. This is based on various expert panel. So their guideline says that fibromyalgia patients' care could be initiated in primary care setting. And the treatment objectives are reduction of symptoms and improvement of function. Non-pharmacologic strategies are the first line. And then second line, or if the patient presents with severe symptoms, then you can consider medications or drugs as first line, like tricyclic antidepressant, muscle relaxant, dual reuptake inhibitors, pregabalin or gabapentin. Since we are prescribing these medications, we should be aware of some of the side effects, because many of these patients will come back to you complaining of these side effects, so you should know the side effects of these medications. So all SNRIs may increase the risk of suicidal ideation. So you have to take also history from your patient. If they have suicidal ideation, then avoid all SNRIs. Other side effects like nausea, vomiting, insomnia, dizziness, high BP, transaminitis, and renal dysfunction. What about tricyclic antidepressant, Lyrica and Neurontin? They can cause fatigue, somnolence, dizziness, weight gain, and sicca symptoms. Weight gain is the main issue in tricyclic antidepressant patients. I don't think, because you are controlling things, we are starting with low dose, and if their symptoms resolve, we don't have to go for a higher dose. Personally, I didn't face any case of addiction to Lyrica. Yeah, so I start with 75 OD, and then after a few days, 3 to 4 days, you can escalate